Good day, everyone. This is Sir Franz, and welcome to our last lesson in drug development. And particularly, we'll be learning developments in the therapy of gout. First, you have to understand that gout is technically an accumulation of uric acid in tissues where there is normally no accumulation of uric acid. So first, let's learn what uric acid is. It's the end product of purine catabolism. So first, remember that purine, these are nucleotides and particularly bases which have two rings in them. And we have two purines, adenine and guanine. So when adenine and guanine are attached with a sugar, we form adenosine and guanosine. And once we add a phosphate group, we form the nucleotides adenosine phosphate and guanosine phosphate. So they can be in combinations such as adenosine diphosphate or adenosine triphosphate and guanosine diphosphate and guanosine triphosphate. So you have here an image literally just showing you that adenosine triphosphate and guanosine triphosphate, when catabolized, end up as uric acid. So let's go through this image. Adenosine triphosphate, once you dephosphorylate it, will form adenosine monophosphate. Adenosine monophosphate, if you remove the final phosphate group via dephosphorylation, you will form adenosine, which is just adenine with the sugar. If you remove a molecule of amine or ammonia from adenosine, you form inosine. So if you remove again the sugar backbone of adenosine, you will form adenine. And if you remove the sugar backbone of inosine, you will form hypoxanthine. Hypoxanthine, together with guanine, which is the dephosphorylated product of guanosine triphosphate, and you remove the sugar from there, you'll form guanine. Hypoxanthine and guanine, if again oxidized by xanthine oxidase, will form xanthine. So let's look at this. Guanine, if you remove an amino group and you add an oxygen, that process is called oxidative deamination. So that will form xanthine. Xanthine, again, acted upon by the same enzyme previously, xanthine oxidase, will be oxidized into uric acid, which accumulates in the tissues of the body abnormally or pathologically in the disease that we call gout. Next, nucleotides in the human body can be recycled through HPRT. HPRT stands for hypoxanthine guanosine phosphoribosyl transferase. So hypoxanthine plus phosphoribosyl pyrophosphate acted upon by HPRT, hypoxanthine guanosine phosphoribosyl transferase, will form inosine monophosphate. And if again you add an amino group here, you will be able to reform adenosine monophosphate. Guanine plus phosphoribosyl pyrophosphate in the presence of HPRT, hypoxanthine guanine phosphoribosyl transferase will form guanosine monophosphate. So what is the key point here? That you have a base without sugar, and then you have activated sugar in the presence of HPRT, the enzyme. They will combine and reform your nucleotide. Okay? For adenine, you have a specific molecule, that's your adenine phosphoribosyl transferase, to form AMP. So what does this tell us? If we have free bases in the cell, we can reform the nucleotides, and that is a salvage pathway. Next, the amounts of nucleotides in the human body are tightly controlled, which means that usually in the physiologic or normal state, the levels of adenosine, guanosine, cytidine, and thymidine are kept in constant amounts. And this is through negative feedback. So you have here an abbreviated pathway for the synthesis of your nucleotides, ATP and GTP. This pathway or diagram just tells us that if we have already synthesized ADP and GDP, they will both slow down the production of PRPP, phosphoribosyl pyrophosphate, which in essence will also slow down the synthesis of the end products. So this is in essence negative feedback, which keeps the levels of ATP and GTP in constant amounts, not too much, not too little. Next, we have disorders in purine metabolism. These disorders eventually lead to gout, which is again the pathologic accumulation of uric acid in the tissues of the body. We have two main disorders that lead to gout, and number one is overactivity of PRPP synthetase, which means that the cell will have an accelerated synthesis of the nucleotides of the bases. And once this accelerated synthesis of the nucleotides is in effect, all of those nucleotides that have accumulated will end up becoming uric acid and therefore gout. Next, you have enzyme deficiencies that lead to the accumulation of bases, and this is in the form of reduced activity of hypoxanthine guanosine phosphoribosyl transferase HPRT. So once your salvage enzyme is inactive, there is no way by which you can convert hypoxanthine and guanine back into inosine and guanosine. Therefore, hypoxanthine and guanine will accumulate, and all of those will be funneled into the formation of uric acid, such as in the case of Lesch-Nyhan syndrome. So in Lesch-Nyhan syndrome, the gene for HPRT is deficient or absent. The gene is encoded in chromosome X. So patients with Lesch-Nyhan syndrome have defective chromosome X. And in particular, the HPRT gene is affected. Without HPRT, again, hypoxanthine and guanine will accumulate, and this will form uric acid. But because hypoxanthine and guanine will not be able to form your nucleotides, the central dogma is also affected. So you have inability to produce the essential proteins of the body and inability to replicate the genome of the body. So if affected, in particular, would be the central nervous system, where lots of proteins are made for the activity of neurons and where there should be constant and regulated synthesis of nucleic acids. So in the central nervous system, this will present as dystonia or inappropriate tonicity of the muscles, choreoathetosis, which is um, purposeless movement, spasticity, difficulty in moving, but that is due to high tension of the muscles, mental retardation, and what's unique here, these patients will have self-mutilating behavior. They will often bite their extremities or cut their extremities, and that is on top of gout. So here is a picture of Lesch-Nyhan syndrome patient. Now let's go into gout. Gout is when serum uric acid is above the limits of solubility, and because these have exceeded the solubility limit, they will form crystals, and these crystals are sodium urate. So when sodium urate crystals deposit in the subcutaneous tissue, as seen here in the image, this is what we call a tophus or tophi. But these are not painful usually. Okay? When sodium urate crystals accumulate in the joints, and classically this accumulates in the first metatarsophalangeal joint. This is what we call podagra. It triggers an inflammatory response, and that is what we see as gouty arthritis. So what's unique here, usually it will present in the first metatarsophalangeal joint of the foot. And so why? Because the foot is the farthest from the heart, and therefore by temperature it will have the coldest temperature in the body. So lowest temperature in the body, uh, less efficient blood flow here will lead to crystallization of sodium urate. Next, you have here the image of uric acid crystals when seen under the microscope. So these are classically described as triclinic crystals of uric acid. So ganyan yung mukha niya. And it just shows that these crystals are sharp and therefore will have the ability to physically disrupt cells and tissues in the body. Next, you have here a picture showing you uric acid nephropathy. So this is a picture of a histopathologic report of the kidney when biopsied. So they saw here that the glomerulus has been filled with uric acid. That's the yellow portion. And this will eventually lead to dropout ineffective nephrons in the body, eventually leading to chronic kidney disease. So now let's go into therapy. You have here the stages by which uric acid is formed and disposed of by the body. You start with the purines, and eventually they undergo oxidation to form uric acid. Here would be the site of activity of our xanthine oxidase inhibitors, allopurinol and febuxostat. So they inhibit xanthine oxidase, which prevents the conversion of hypoxanthine into xanthine and xanthine into uric acid. Uric acid will then um, be converted into allantoin in mammals and in other life forms except humans. So this portion of the pathway here is absent in humans because we do not express urate oxidase. Next, uric acid, if it does form, can be eliminated through the urine by the uric acid anion transporter in the proximal convoluted tubule. So this pathway of uric acid elimination is stimulated by sulfine pyrazone. Next, what was absent in humans, that's urate oxidase, can be circumvented by the introduction into the human body of uricase, that's urate oxidase, but in the modified form, which is rasburicase. And once rasburicase has been introduced, uric acid will then be converted into allantoin, which is water soluble and therefore easily eliminated in the urine. So we have here the treatment of acute gout. And first, we have colchicine. Colchicine interferes with the function of neutrophils by disrupting the activity of microtubules. So you have here in the image in the right the normal functions of microtubules in the body. So microtubules are specific forms of the cytoskeleton, and they are important in the proliferation of cells in mitosis. They are important in maintaining cellular shape and function, in particular in skin cells, in the epithelial cells of the small intestine, and um, through its non-centrosomal function in neurons. It is important in the transport of neurotransmitters, which are synthesized in the nucleus, in the soma of the neuron, down the length of the axon into the axonal bottoms or terminals. It is also important in coordinating muscular contraction, and this is seen in smooth muscles and in heart muscles. So, um, because colchicine inhibits microtubule formation, it also inhibits movement. So neutrophils are technically paralyzed and they are not able to cross from the blood into the site of uric acid accumulation. So if your neutrophils will not be able to go into the joint, they will not be able to elicit an inflammatory response. So colchicine is given once the pain has started. So you have a golden period of 6 to 8 hours. So for example, a patient with acute gouty attack uh, has pain right now. He has 6 to 8 hours to take the colchicine, and that is the period of highest effect. So he takes the colchicine repetitively every 6 to 12 hours until the pain resolves. So, a unique toxicity of colchicine is gut toxicity, and that is due to inhibition of mucosal cell division. Because you have inhibited the activity of microtubules, and that involves cytokinesis during mitosis, then your mucosal cell will not also divide. That will lead to gut toxicity. That's why these patients will often present with diarrhea. Another therapy for gout would be treatment of hyperuricemia, which, as I will emphasize, is not um, a clear indicator of gout. You can have high levels of uric acid in the blood but not present with gout. So this just tells us that hyperuricemia or high levels of uric acid is a risk factor for gout. So some patients who have repetitive gouty arthritis attacks will benefit from lowering of uric acid in the body. So we have here treatment options for hyperuricemia. Number one is inhibition of xanthine oxidase, which again will decrease the levels of uric acid. So we have two agents for that, allopurinol and febuxostat. Allopurinol looks like hypoxanthine. And so instead of catering hypoxanthine, your xanthine oxidase will take up allopurinol and therefore become inhibited. Febuxostat, on the other hand, also inhibits xanthine oxidase but does not look like hypoxanthine. Febuxostat is also more potent than allopurinol. Because these agents all in all inhibit xanthine oxidase, they have a potential drug-drug interaction with our anti-cancer agents mercaptopurine and azathioprine, which are degraded and eliminated from the body by xanthine oxidase. So can you just imagine what happens if you are a patient taking azathioprine, an anti-cancer drug which is highly toxic, and you're also taking in xanthine oxidase inhibitors, then azathioprine levels in the blood will increase and lead to toxicity, which is not an unusual scenario in patients who have lymphoma and leukemia, who are given azathioprine but at the same time given xanthine oxidase inhibitors for the prevention of tumor lysis syndrome. So next you have urate oxidase analogs, and this is in the form of resburicase. Remember that urate oxidase catalyzes formation of allantoin from uric acid, and this enzyme is present in mammals except humans. Sobrang malas naman natin. Resburicase, on the other hand, is a genetically modified urate oxidase from Aspergillus flavus, which is a fungus. So we use resburicase as prophylaxis of hyperuricemia during the treatment of cancer with chemotherapy. Remember that when chemotherapeutic agents work, they literally kill tumor cells. And these tumor cells who have high activity of DNA synthesis, they die and spew out all of those nucleotides into the plasma. And all of those nucleotides will then undergo catabolism and form uric acid. So when you give chemotherapy, you have the propensity to really have hyperuricemia. So we prevent that by giving prophylactically rasburicase. And lastly, you have here your uricosauric agents, or technically agents that increase the elimination of uric acid through the urine. So we have two agents here, probenecid and sulfenpyrazone. Probenecid is not really used right now as a uricosauric agent because it is less effective, plus it is toxic. But you can still see probenecid in combination with penicillin. So penicillin is eliminated via urinary elimination. So if you have a difficult time maintaining the plasma levels of penicillin, you can give probenecid to prevent the elimination of penicillin through the urine, and therefore prolong the duration of action of penicillin. Next, sulfenpyrazone is an inhibitor of the urate transporter in the proximal convoluted tubule. So, by inhibiting this transporter, um, your uric acid will stay in the apical membrane here and be eliminated in the urine instead of being reabsorbed. So you have here an image showing to you the kidney, the nephron, and in particular, the proximal convoluted tubule. So you have here the apical membrane or the urine side and the basolateral membrane or the blood side. So you have here different transporters that catalyze the transport of uric acid. So for example, you have your GLUT9B, which reabsorbs together uric acid, glucose, and fructose. And this is one of the reasons why if you have a high sugar load through the diet, particularly fructose, it will also lead to an increase in uric acid. Another one is of particular interest to us is your uric acid anion transporter, and this facilitates the reabsorption again of urate. But you have agents here, for example, salicylates and your thiazide diuretics, which produce an increase in the activity of your uric acid transporter, and this will lead to an increase in reabsorption, and therefore if you use these agents, you will have high levels of uric acid in the blood, which is a metabolic complication of the use of thiazide diuretics. Probenecid will also do that, but at the same time, it will also inhibit the uric acid transporter. So it has mixed effects. Um, on the other hand, your sulfenpyrazone, metabolite of pyrazinoate, will have anti-Uricosauric agent activity. So this image just shows us that you have mixed effects once in the kidney, and therefore this is less an effective site for the control of uric acid in the blood.